exercise sports science department, and my study is on the impact of nicotine vaping devices on exercise-induced vascular benefits and exercise capacity. Cardiovascular disease is the leading cause of death globally, and it is predicted to increase throughout 2025. Cardiovascular risk factors include age, family history, obesity, dyslipidemia, prediabetes, sedentary lifestyle, and smoking. The two most modifiable risk factors and the risk factors we're most interested in for this study are sedentary lifestyle and smoking. With the widespread issue of cardiovascular disease, it has led to an abundance of studies showing the positive benefits exercise has on overall health, but more specifically cardiovascular health. Exercise has been long proven to have cardioprotective dose-response effects, meaning to a certain extent, the more you exercise, the better cardiovascular health you'll be in. Referring you to this study over here, we can see the individuals that are non-runners that lead a sedentary lifestyle. As a result, they're at the highest risk for cardiovascular mortality. As we move down the x-axis, we're going to see individuals that are running more frequently at longer durations of time at higher intensities, and as a result, they're lowering their cardiovascular risk for mortality. It's also important to note that they are reducing their all-cause mortality due to exercise as well. Some of the mechanisms in which exercise promotes cardiovascular health includes reducing resting heart rate, reducing the heart rate at any submaximal absolute intensity exercise, which improves the efficiency of the heart, improves vascular function, and reduces overall blood pressure. The body also makes structural adaptations during exercise training. Some of these include increase in erythrocyte mass, increase in mitochondrial density and size, increase in mitochondrial enzymes, and an increase in capillary density. All of these mechanisms help to promote the transportation and utilization of oxygen, which increases overall aerobic capacity and, as a result, overall exercise capacity. The way we test exercise capacity is a VO2 max test. VO2 max tests allow us to read how much oxygen is being consumed and utilized by the runners. It's also important to note that these changes can occur despite a lack of weight loss, meaning the two risk factors of sedentary lifestyle and obesity are independent of one another. If an individual begins exercising, they will still see cardioprotective dose-response effects despite maybe not losing weight. One of the most well-known risk factors for cardiovascular disease is the use of traditional tobacco cigarettes, as they account for 10% of all cardiovascular cases. Two things that traditional tobacco cigarettes introduce into the body are carbon monoxide and nicotine. As you can see over here is a red blood cell that have 4 heme binding sites. This is where oxygen binds so that it can be transported throughout the body and utilized for aerobic respiration and everyday needs. When carbon monoxide is introduced to the body, it has a higher affinity for heme binding sites than oxygen does. Therefore, it will bind and oxygen will not be transported throughout the body as efficiently as it should be with the absence of carbon monoxide. Nicotine is also introduced in the body, which stimulates the release of catecholamines like epinephrine and norepinephrine. These stimulate the sympathetic nervous system, which increases heart rate at times when it doesn't need to be increased, and overall augments the workload of the heart. Fortunately, with all this data, traditional tobacco cigarette use is on the decline. However, a new product has inevitably filled its void. This product is marketed as a safer alternative to traditional tobacco cigarettes. These products are known as electronic cigarettes, e-cigarettes, vapes, or as we refer to them in the study, electronic nicotine delivery systems, abbreviated as ENDS. Rather than a safer alternative to traditional tobacco cigarettes, ENDS devices have become widespread among a young, otherwise healthy population that has never used tobacco products prior. Electronic nicotine delivery systems, or ENDS, vaporize different flavors of an e-liquid containing flavoring agents, chemicals, nicotine, and it has a power source that heats up the e-liquid and allows it to be vaporized by users. With ENDS still being relatively novel, we lack significant research. However, some studies have investigated the similar effects in traditional tobacco cigarettes and have seen similar trends. This study took a look at the acute effects of e-cigarettes as well as traditional tobacco cigarettes, comparing it to baseline measures. We can see an elevation in our traditional tobacco cigarette group, and then we see similar trends to our e-cigarette group, but to a slightly lesser extent. There's very minimal research on the exercise capacity effects of e-cigarettes. However, one recent study just showed a reduction in oxygen consumption peak in an e-cigarette group when compared to a young healthy control group. One study also took a look at the acute effects of transcutaneous oxygen tension, which refers to the partial pressure of oxygen in the tissues. They found a 10-minute acute reduction when compared to a control group, where we can hypothesize a lower oxygen level in the tissues could correlate with a lower overall exercise capacity. Our research question is, how does ENDS use affect the cardiovascular responses and exercise capacity? For our study, we used individuals in between the ages of 19 and 35. These are defined, we have a control group and a non-control group. The non-control group are habitual ENDS users, defined as using ENDS devices daily or most days within the last 30 days for a 6-month period of time. We also have a nicotine naive control group. We utilize both men and women in our study. We have a pre-study 12-hour abstinent period from caffeine, nicotine, alcohol, and then a period from abstaining from vigorous activity that might enhance exercise performance. So for study methods, I'll start with our e-cigarette group, or our non-control group. As run concurrent with the control group, we have a familiarization trial. The familiarization trial aims to get some baseline data as well as a perceived raised pace for their VO2 max test, and then just get them familiarized with all the equipment. We then have 2 data collection trials for our e-cigarette group. These trials are the same with one distinct difference. Before exercise, we require a 60-minute rest phase. One trial, the individual will rest during this phase, and the other trial, they will use their e-cigarette during the 60-minute pre-exercise phase. This is to incorporate acute effects as well as chronic effects. So it's randomized, so on trial 2, if they use their e-cigarette during the 60-minute span, trial 3, they won't, and vice versa. So we take baseline measures, then they rest or vape for 1 hour, then we take post-rest or vape measures depending on the trial. They then undergo the VO2 max test, which I'll explain later, and then a 10, 20, and 30-minute post-exercise measures. We have, as well as I mentioned, a control group. The control group is almost identical to the e-cigarette group. However, the trial in which they use their e-cigarette is omitted. So they only have the 60-minute rest data collection trial. We use a polar heart rate monitor, and then we use a common blood pressure cuff, and then we use a sphygmocord to get our pulse wave analysis, as well as our carotid femoral pulse wave velocity to determine arterial stiffness. For our VO2 max protocol, it's very individualized. We get a race pace on our familiarization trial. For this particular individual, their race pace is 8.5 miles an hour. We start 2.5 miles an hour below race pace, and we have a 5-minute warm-up phase. Every 1 minute, we increase 0.5 miles an hour until they reach their race pace. Here it's 8.5 miles an hour. Then the incline increases 2% on 2-minute increments. Therefore, they will run for 2 minutes, 8.5 miles an hour. 8.5 miles an hour will not change, but 7 to 9 minutes they'll run for 2%. And then if they made it 9 to 11, 4%, 6%, 8%, so on and so forth until failure. Our hypothesis is END's use will yield a higher pressure response and a lower exercise capacity, and then our control group will have a better overall cardiovascular profile. So for some of our results right off the bat, we have 15 control subjects, and then we have 10 e-cigarette user subjects. We have very similar BMIs between the different individuals. We use both male and female for both groups. The age is significantly older for our control group, 24.4 when compared to 21.1. Then we have fairly similar body fat percentages between the two groups. The METs per week for exercising was slightly higher for a control group, but part of that is to account for a large standard deviation in one individual. Vape quantity, obviously, for our control group is going to be 0. The average inhaled liters was 31.8 for our e-cigarette group. And then we have a VO2 max average of 50.1 for our control group. This is split into 2 boxes for e-cigarette group. As I mentioned, we have a trial in which they are abstinent from nicotine and don't use it during the 60-minute span. And then we have the trial where they do use their e-cigarette device during the 60-minute span. As you can see, we saw significant data that they lowered their overall VO2 max when they used the e-cigarette in the 60-minute span versus when they did not. You can compare that with the 49.2 and the 47.1. We also took a look at just the resting systolic blood pressures. So this precedes the rest vape phase. This is right when they come into the lab. We saw a resting systolic blood pressure of 113.8 for our control group, and then our e-cigarette group, depending on the day, was either 124.3 or 125.4, and that's statistically significant difference at baseline. So to look at some of our results as well, we'll start in the upper left, looking at aortic systolic blood pressure. The gray bar is going to be our control group, our nicotine-naive control group. The blue bar is going to be what we call our time control group. This is the e-cigarette users on the day when they were absent from their nicotine and only rested during the 60-minute span. And then we have the vape group, which is the same group as the blue group, except this is the day in which they use their e-cigarette during the 60-minute span. Starting with our gray bar, or our control group, we saw exactly what we would expect to see in a young, healthy population. They showed post-exercise hypotension, meaning blood pressure dropped acutely, 10 minutes acutely after exercise, and remained below baseline measures 20 and 30 minutes after exercise. This was not the case in either of the e-cigarette groups. Not only did they not decrease their aortic systolic blood pressure, but their blood pressure elevated 10 minutes acutely after exercise and remained high 20 and 30 minutes after exercise. Statistical significance here shows a difference between our control compared to our vape group, and this symbol on all three, 10, 20, and 30 minutes post, shows statistical significance between our control group compared to both of the other groups. We saw similar data and the same trends with our brachial systolic blood pressure. Another thing we investigated was the mean arterial pressure in these individuals. Baseline was not statistically significant, so this is after their rest or vaping phase. However, 10 minutes, 20 minutes, and 30 minutes after exercise, both the e-cigarette groups were significantly higher than the control group. We elevated slightly, as we would expect to see in young individuals, for the mean arterial pressure, and then we remained very similar to that baseline measure. This was not the case in the e-cigarette group. We elevated disproportional to the control group. Something important to note is that heart rate showed no differences at all. You can see those are almost identical, both at rest as well as 10, 20, and 30 minutes after exercise. So to discuss some of the things we discussed about the results, overall exercise capacity was reduced in our e-cigarette group when they did vape versus when they didn't. So days they came in and vaped during the 60-minute span, they had a lower overall VO2 max compared to the day when they were abstinent from the e-cigarette. However, we saw no exercise capacity effects between the control group and either of the e-cigarette groups. We took a look at systolic blood pressures, both aortic and brachial. Both of these showed us that our control group had post-exercise hypotension, and not only did both e-cigarette groups not have post-exercise hypotension, but they elevated blood pressure 10 minutes after exercise and remained elevated equal to or above baseline measures 20 and 30 minutes after exercise. As I mentioned, we also took a look at mean arterial pressure. One important thing to note is that mean arterial pressure is calculated by cardiac output multiplied by the systemic vascular resistance. And as I mentioned, heart rate had no differences. Heart rate is one of the two things that's going to innervate our cardiac output. Heart rate multiplied by stroke volume is going to equal our cardiac output, and then we have our systemic vascular resistance. If we take a look at some other studies that show the effects that exercise should have on young, healthy individuals, we can see these bars up here are going to indicate different forms of exercising. So this is a bike run, jog. So this is exercising. These are control when they were just resting. So we can compare it to what their resting measures would be. We can see that our cardiac output should be elevated after exercise. However, to account for a same mean arterial pressure, this systemic vascular resistance should be reduced. Because we saw a higher mean arterial pressure and we already expect cardiac output to be up, we can conclude that could be likely that the effect in the e-cigarette group could be due to systemic vascular resistance rather than cardiac output seen in the no change in heart rate. One other important thing is the demographic age. So we had an average age for our control group of 24.4 and an average age in our e-cigarette group of 21.1. As a lot of you know, blood pressure, arterial stiffness all increase inevitably with age. Therefore, you would expect an older group to see slightly higher blood pressure. However, this wasn't the case. Our 24.4-year-old average control group had a lower resting blood pressure and better blood pressure responses to exercise than our younger e-cigarette user group. So overall, I'd like to thank the College of Health and Science for a Dean's Distinguished Fellowship and a undergraduate research grant for allowing me to work on this research for the last few years. My mentors, Dr. Salvador Jaime, Dr. Ward Dobbs, Dr. Jacob Codwell, and then everyone in the Human Performance Lab, such as Chris Dodge, Ben, Kate, Nate, and Brett, for their help along the way. These are my citations and any questions.